welcome to the Concussion Discussions series brought to you by Integrated Brain Centers. I am your host, Amy Zellmer from Faces of TBI, and today I am here with Dr. Elizabeth McNally from Midcoast Chiropractic Neurology, and we're going to be talking all about headaches today. So welcome to the Concussion Discussions.
Thank you for having me.
Yeah, this is exciting. So the topic of headaches and in the TBI world, I mean, this is probably one of the top complaints that I see. I'd say the vast majority of people with a concussion are dealing with some type of headache. So maybe where would you like to begin with this conversation? Maybe even just like defining what a headache is?
Yeah, so a headache can be like different things. So some patients might describe it as like this feeling of a lot of pressure in their head, a lot of pressure at the base of the skull, for example, in their forehead. It can be pain, straight up pain, sharp pain, kind of a dull, achy type pain. There's different types, and it can be like one side, it can be the whole head, it can start in your neck and kind of travel up. But more or less, it is an abnormal feeling in your head, an area that you shouldn't normally have aching in. Kind of sum it up in that regard. And there's this whole level of classification of headaches that's super, super extensive, but any that occur as a result of or following any type of head injury or any type of trauma at all, but especially head injury, because it's not one of the number one symptoms that continues to be an issue for patients, both acutely, so like within those first couple months or weeks following the initial injury, but then it's also one of the most common chronic symptoms that patients experience, and those are considered what we call post-traumatic type of headaches. But again, that doesn't necessarily define them. It just kind of gives them a category to be put under. And so in terms of like looking at them and defining them a little bit more, that's kind of where it comes in with being able to differentiate what the source of it is for a patient.
And so let's actually talk about that. How do you dig in with a patient when they say, I have a headache? Because like you said, headaches can come from an array of different reasons. So what are some of the ways that you kind of dig in with a patient to kind of figure out what's actually going on?
Yeah, so that's a good question. So someone's history, I think, it plays. I mean, we know as physicians and stuff, it's so important, which is why we ask so many questions when we first do intakes with patients, is because someone's health history can play a huge role in their diagnosis and in determining what's going on with them too. Not just the history of the injury, if it's a concussion patient or TBI patient when they come in, but also their history preceding that injury. And so did they have headaches in the past? Did they ever experience symptoms like this before? And what we'll see a lot of the time is that, and not necessarily all the time, but it's not uncommon that patients, for example, that had a history of migraines or chronic or episodic tension type headaches, that they have a head injury and then they get kind of just told like, oh, hey, it's just your same headache is your other one, but their symptoms are different. And then I kind of start to dig into it. So they've been given medication and they're like, but the medication's not working. It used to help with these other headaches. So you start asking them like, what does it feel like? Is it painful? Is it aching? Kind of like let them describe. Sometimes they have a hard time finding words. So I'll kind of give them like a big pool of words, just to kind of help to see if any of those, and then they're usually able to like really tease out and say, yeah, okay, it's like a pressure, but like I feel like I'm floating at the same time, like stuff like that. And then also like location. Does it start like at the base of your skull? Does it start in your neck? Do you feel it? And does it start behind your eyes? Or in your forehead area? And so getting a kind of glimpse into where is it happening? Where do you feel it? The frequency of it. like how often is it happening? How many times a day, week, month? And then another big thing is triggering factors. Is there anything that you know triggers it? So some patients, it's kind of like, no, I don't know. It just happens over the course of the day, or I wake up with it. Or it always comes on when I'm reading, or when I'm driving. And so stuff like that really helps to kind of narrow down in terms of saying, okay, so I already kind of have an idea in my head of where I need to be looking during the clinical exam. But at the same time, I'm still going to be looking at all these other factors that contribute, but it kind of gives me a little bit of a glimpse into kind of like what avenue I'll probably end up going down, and kind of putting a little bit like additional focus in my exam and my testing in by gathering all that information ahead of time.
Mm-hmm. Yeah, and I think, it can be hard to come up with the words to
Mm-hmm.
describe a headache. And I was one of those people that had headaches prior,
Mm-hmm.
and I knew my headaches, mine always stemmed from my occipital, and I
Mm-hmm.
kind of already knew that. And then when I had my injury, I had pretty significant whiplash with my injury, and I
Right.
tore, a bunch of muscles. And um I was 2.5 years in before I found Funk Neuro, and like my headaches, I mean, I was having multiple headaches a month. Like, I mean,
Mm-hmm.
like they were very regular. And it was amazing to me how fixing my eyes
Mm-hmm.
helped resolve a lot of the neck tension
Yes.
issues.
Yep.
And so that fascinated me. And so maybe do you want to touch on that a little bit, on how that's connected, and how if your eyes are off, it can be causing your neck and headache.
Yeah, so our eyes are very intimately connected with our neck and our head position. So our vestibular system, our cervical spine, well, our whole entire postural system anyway, and these
Right.
neural networks that control tone down to our postural muscles. So how we angle, like how we hold our body, what angle are we at? Do we have a head tilt? And a lot of the time those things are happening because of this signaling in our brain that's occurring that is just a little bit um, it's a little bit off, like it kind of got like knocked off kilter, we'll say. So something that might have been firing at like a good regular rhythm before kind of just starts firing a little bit more spontaneously, or it slows down its firing. And so what happens a lot of time with people when they have things going on with their eyes is whenever your eyes move, it's not just about your eyes that this is happening in. So all of these other areas in your brain need to be functioning properly to be able to move your eyes. But then if they're moving when they shouldn't be, such as like if you're not using them for like vision. So I do a ton of testing with patients, for example, where I put the goggles on with the VOG, but then I put the cover over them, and I get testing, and I have them just try to hold their eyes statically so they're not using vision. It's called vision occluded testing. And I'm looking to see, do their eyes spontaneously move when their head is just still and they're looking straight ahead, when they're looking to the right, to the left, up, down. And then what happens when they turn their head and they don't have to use their vision to try to stabilize? Are their eyes spontaneously moving then? And if that's happening, and then I take off the cover and then I test them and look at their eye movements when they are actually using their vision. And there is a difference in them, or you might see the same thing happening. But a lot of time then there's this whole compensation happening for something that's already abnormal going on kind of
Yeah.
underneath. And that a lot of times, so every time our eyes move, we get these signals in our brain that have to come down to control our postural tone. And so if I want to turn my head to the right, but then look over to my left side, I need to have this nice harmonious firing of signals in my brain to come down to control so that my whole body, number one, doesn't fall off to the right side. Or if I quickly shift my vision over to the right, that I don't suddenly fall that way too. So in order to have that, we need to have this nice kind of baseline firing. And then we need to have this dynamic firing down to postural muscles. And so when our eyes are moving constantly, when they're not supposed to be, or when we're trying to fixate on something and they're moving more than they should be, our brain's working overtime and we keep thinking that we're moving essentially,
Mm-hmm.
and muscles kind of get constantly like turned on and off, on and off, on and off. And that will create a lot of tension in your neck too.
Mm-hmm. Yeah. And I remember for me with the cover on the goggles,
Mm-hmm.
my eyes were just like
Mm-hmm.
they kept moving. And, I had been telling every doctor who would listen to me, I had told them it felt like I was moving when I laid down at night and closed my eyes. I felt like my eyeballs were moving around in my head. And
Yeah.
that's essentially what they were
Well, I was
doing.
just gonna say that's what they were doing. It sounds like. Yeah, and that's the thing. That's why like looking at things from that lens and being able to see what's happening when vision is occluded. So like when you're not actually fixating on something, because there's just the eye movement is such a huge window into brain function. Eye movement during actual visual tasks and eye movement like during non-visually mediated tasks. So like we were just talking about laying down to go to bed at night, or sitting there or standing there. Sometimes I'll test patients, they might be great when they're sitting, and then I'll test them when they stand up instead and compare their seated test to their standing tests or something like that too, because you want to see what do these other influences. When I'm sitting, the amount of work my brain needs to do to keep my posture intact is a little bit less than when I'm standing, because then I need my legs to really be working,
Mm.
to maintain that upright posturing too. So I need a little bit extra boost there. But if your system's constantly working so hard just to try to keep your eyes from not constantly moving around, then it's almost like this other effort becomes fatigued.
Mm-hmm.
Other effort that you don't even know is happening, more or
Right.
less.
Mm-hmm. That's why we're tired so easily.
Exactly.
Um, and so then what about, I know another complaint that I hear is people feel like they have pressure in their head and they can hear like their heartbeat whooshing in their ears.
Mhm.
Um, so maybe let's address like that type of headache as well.
Yeah, so that's one that comes with a lot of time with like dysautonomia type stuff. So it comes with an issue with the blood flow, and maintenance of blood flow to like from the rest of the body and then up into the head and that. And so we see that a lot with those dysautonomic patients and what'll happen sometimes is that what they'll say is, either sometimes the headache can start right away when they change position and they get up. But for other people, it's over the course of the day. Just being upright and working against gravity is so difficult. And it's because we need to be able to continue to shunt blood up to our head, and up to our brain and stuff. And then tack on the fact that every time our brain fires to do a task, for example, the area or the areas in the brain that are working for that task need more blood flow. And so you're already trying to keep this baseline going to keep good oxygen getting up to your brain and that. And then if you can't perfuse properly, you're going to have these changes with this pressure and all that. And that's a lot of time what we see. So it's like this orthostatic component, that being up against gravity
Mm-hmm.
over time can really influence. And so these patients sometimes will feel much better when they lay down. And what I hear sometimes too, or actually more often than not, is in patients who are experiencing this, if I'm checking them, whether it's like on the tilt table to see what their response is when they have to get up, but they're not doing as much active movement to get up, the table is helping them. So their postural responses again are different. Then when they actively get up from laying down on the table and go and stand up, is that when they do go from standing or sitting to laying down, they're like, I feel like all the blood is like starting to come back up to my head. Like they'll literally just describe that. And I'm like, well, that's exactly what's happening, because now you don't have gravity pushing downward. So your system isn't having to work as hard to push blood upward. Now it's all kind of like dispersed. Gravity's coming down this way, but if you're horizontal, everything still gets kind of dispersed out this way. And so that's definitely another common thing. So it's like, but my headache gets better if I lie down. And a lot of time it's because of that orthostatic component with that dysautonomia too.
Mm-hmm. And then what about nerve pain? I know that that's another common reason people have a headache.
Yep.
And that's more of, I guess you'd say, a pain, right?
Yep. Yep. So you can have, there's different sources of that. So some people might have the pain it depends on like the nerve distribution. So we can have pain that comes from some of the cranial nerves that supply the sensation to our face, for example. And it's because there's, you know, irritation and excessive firing in those guys. So like a little bit of stimulus sets that off. But another thing though, that's very common, especially in head injuries where we've got some type of like a neck, like a whiplash type injury too, is we end up with this kind of shearing on the nerves that come up, and they supply from the back of the head and up behind the ear, base of the skull, down into the neck area and through here, front of the neck. And those all come from what's called our cervical sympathetic plexus. And so they all kind of, there's a little bundle of nerves like right in here, and they all kind of branch off from there. And that I often see as patients are like, I feel like there's this like pain and it just kind of comes from here and it goes up. And you can kind of trace, when we know the distribution of where these nerves generally supply, the areas that they supply, and you can kind of trace along that, and it's exactly the distribution of the patient's pain. You can say, okay, so we know what's coming from irritation here. It's not necessarily, a lot of time what we see is that it'll be the nerve irritation. So the nerve gets irritated. And then we've also got these changes in muscle tone happening. And so sometimes though, the muscle ends up tightening up as a reaction to the level of pain. It's almost like a protective type thing. So sometimes just helping to neutralize, there's this, some colleagues several years ago developed a product, and it works phenomenal to help to neutralize some of the superficial like inflammatory mediators that particularly target superficial nerves. And so I'll use this stuff called Prolo Gel, and if I'll apply that there. Yeah, it's awesome. And apply it there. And you'll know if it's coming from those nerves, it's like a great differentiator, like really quick, super quick differentiator that within a minute of applying it along the distribution of that nerve, or finding like the little areas where you can feel some inflammation in that, applying it there, and all of a sudden I palpate the area again to check and see, or the patient, and like the pain's gone to palpation, or the patient just like sitting there is like, my headache is already starting to, or like this pain is starting to go away. But again, kind of going back to the fact that we have this shearing and like irritation of those nerves, but a lot of the time that's associated with all of these other aspects that are going on, whether it's changes in joint angulation or muscle tone, firing down from the cortex and brainstem areas. So treat the superficial component, get that inflammation down, and then also got to treat the brain-based component of it too.
And so I have a question for you in regard to like barometric pressure. I know for me, mine's more in the winter before we're getting like a snowstorm, a winter storm. I don't struggle as much with summer, but I know some people struggle with both. Some people struggle more with summer. How do you explain that? A lot of medical doctors will say, oh, that's just not even true. It's not a real thing. But like, seriously, I could predict the weather and like, it just flares up my headaches. So, what do you have to say about that?
One of the simplest ways I usually explain to patients is that, so we have these pressure receptors in our system and these chemoreceptors in our system, right? And so they affect how they affect like blood pressure, heart rate, all that type of stuff. So if we have changes in our environment, it's going to impact how we need to perfuse blood and any other of those autonomic type responses in that too. So like say, you go outside in the winter and it's really, really cold. And so blood vessels might constrict, and sometimes that's where your fingers will really start to get. And so impacts from with the barometric pressure and the atmospheric pressure in that, our body's mostly water. So when it comes down to it, so you got to think about how does that impact the, just like the tide with the ocean. So you're going to get changes in those coming into those receptors, and your system is going to adapt to it. But if it's already not adapting to like at a baseline really well,
Right.
then the ability for it to adapt to changes in the environment that are kind of outside the normal changes is going to be a little bit more difficult for it to do. So it's usually like the kind of most simple way that I explain it to people, if that makes sense.
Mm-hmm. Yeah. Yeah, because I know it comes up in our group all the time, right? Like, can anybody else, guess the weather based on their headache or their neck pain too? That's another common.
Yep.
um
And in like systemic inflammation is also plays a role in that as well. And that comes down to like nutrition and neurochemistry and all of that too, because we have these natural inflammatory processes and cascades that occur after a head injury. And if our system's already inflamed, or the immune system isn't kind of regulating those inflammatory factors, and so that cascade or that network of neuroinflammation gets upregulated, and then it can't naturally so it's like we should have this normal process where it should come in because it's an injury. We've had an injury, and so that's how this system is supposed to work. But if we're already inflamed, whether it's from what we eat or the environment that we live in, because of the air we breathe or anything like that, then our ability to regulate and to kind of shut that down and like drop that cytokine expression, which are those inflammatory mediators in the brain, and that is going to be that much more difficult.
Yeah.
And it will perpetuate a lot of these type of symptoms and complaints too. So the inflammation component does definitely play a role there as well. Mm-hmm. And it's hard to separate them all.
Yeah.
All these
They're
pieces,
also interconnected.
Everything is associated. Yep.
Well, Dr. McNally, this has been a wonderful conversation, and I just want to remind everyone that all of your information is below this video, but if they want to get in touch with you, your website is midcoastbrain.com, and you are Midcoast Brain on Instagram. And if anyone would like to learn more about working with you, they can reach out and schedule a consultation with you, correct?
Correct. They definitely can. Yep.
Thanks for watching. I hope you enjoyed today's video. Be sure to hit that subscribe button so you don't miss any videos in this series. Like this video and head to Amazon to purchase Concussion Discussions.